headquartered in Rome, Italy. In Ethiopia, GCY conducts educational programs only in collaboration with Ethiopian Dental Professionals Association and dental experts, an official affiliate of GCY. We have no association with any other organizations, academies, or individuals in Ethiopia. Any person or entity claiming affiliation with GCY outside of the above partnership is unauthorized and not officially recognized by GCY. Please contact us directly for verification or further information. Myself, Dr. Jabin George. I am from Cochin, India, South India. So I belong to the state of Kerala, which is near the Indian Ocean. One side it is Arabian Sea, below it is Indian Ocean, and very close to Sri Lanka. And I'm a consultant implantologist to Ethiopia for the past 10 years. I travel every month. I used to travel every month to Addis, and I was operating in few clinics in Addis Ababa. I have a lot of friends in Addis Ababa. So let me introduce my city and my center. This is the beautiful Kochi city where I live. And this is my center where I practice. And this is Marine Drive. And you can see the Rainbow Bridge. This is our metro. And you can also see the houseboat. We have a lot of water bodies here, a lot of rivers, backwaters. So tourists enjoy staying in the houseboats. And this is my team. Not all of them are faculty for the implant program which we are organized, but many of them are faculty for the program. This is my team who is going to teach in this program. We are starting the on-site session on 28th of August. We have online and on-site lectures. And this is a GCY accredited program. The participants will get an opportunity to do hands-on on models and also on patients. The first module is planned for 4 days, and we have around 16 registrations now. We cannot accommodate more than 20 people. So if any one of you wish to join, this is a golden opportunity. You can join before the on-site session begins. And this program, since it is affiliated to GCY, participants can get GCY credentials, that is fellowship, mastership, and diplomate. And you will definitely get continued support from all the faculty who is going to teach you. And we'll be forming a WhatsApp group. And in that group, you can submit your cases. We can have a case discussion. We will guide you how to go about the cases. And this is also a bridging program for Master of Surgery in Implant Dentistry with the Italian University. So anyone who complete this program and wish to join for Master of Surgery in Implant Dentistry, they can. In future, they can join for Master of Surgery in Implant Dentistry, which is a university level program. And This is the Camillus University, where we train our participants in MS implant dentistry. You need to go there only for a week. All other sessions are conducted in Addis Ababa, and other sessions are online. And the final module you have to go to Rome. You have to submit your thesis and you get your certificate. We conduct programs all across the globe. This is from Indonesia. We had basic implant program in Indonesia last year. And this is from Malaysia. And this picture is from Myanmar or Burma. We had a program there, and GCBOY has a study club there. And this is our Addis Ababa. We had conducted many programs in Addis. And this is from India. On a regular basis, we conduct programs in India. And this is from Sri Lanka. For the Sri Lankan dentists, we have conducted a few programs. And this is the university where we are affiliated to. Those who wish to join for the Master of Surgery in Implant Dentistry can join after completing the basic implant program. And this is our center in Addis Ababa. It's in Bole Atlas, Tertera building, 5th floor. The center name is Dental Experts. And last week, we had a wonderful program in orthodontics by Dr. Binoy. You can see the picture which we have taken during the program. The interesting thing about this program is we had participants from many of the African countries. That was the interesting factor about the program. We invited all our friends, colleagues in Africa to come to Addis Ababa, and we conducted the training program in orthodontics. This was the first of its kind program we had last week in Addis Ababa. These are few pictures from the class. This is our center in Addis. And we had participants from Burundi, Kenya, Nigeria, Somaliland, Zimbabwe, many of the African countries, and of course from Ethiopia also. They all enjoyed the traditional food, and we visited the cultural restaurant, and we all had a wonderful time. So in the photograph, you can see our colleague from Burundi. She is the president of Burundi Dental Association. She is enjoying the bunna in Uletsa Habesha. And also we enjoyed the tips. You can see our faculty, Dr. Binoy, is enjoying the bunna. We had bulla and Habesha egg, everything. We really enjoyed the food there in Addis. And this is the program coming up in November first week. We have another session, which is again, it's on fixed orthodontic therapy. Those who wish to join for this program, you are welcome. You can contact EDPA, Dr. Meron, Dr. Fasik, or any officials of the EDPA, and you can register for this program online. This program is about implant industry. So I want to speak about the history of implant industry, how implants are evolved. You know, in ancient civilization, in 2000 BC to 1000 AD, people were trying to have fixed teeth. They used, this is a fossil from ancient time. They were the Egyptians, Chinese, and Mayan civilization. They used bamboo pegs, carved stones, and even shells. They tried as an implant, but that was not successful. We could find these type of specimens in the archaeology department. Then in 18th to 19th century, people tried to place implants made of metals. But due to sterilization problems and biocompatibility, lack of biocompatibility of those metals they have used, it failed. Then in 1930 to 1950, Leonardo Linko introduced subperiosteal implants. This is a unilateral subperiosteal implant which was used to fix a unilateral denture, mandibular posterior region. They restored the teeth using this implant. We can call this as the first implant which was made of metal, used and successful in a human being. Then in 1952, Professor Brainemark discovered the phenomenon called osseointegration. He was a Swedish orthopedic surgeon who was doing some studies in animals, and he has placed titanium cylinders in animal bone. And when he tried to remove it, he couldn't. Then he thought, why it is not coming out? Then he discovered the osseointegration. Osseointegration is the close association of titanium with the bone. Once you put in the titanium into the bone, it integrates. So from there, the new era of implant dentistry started. And Professor Brainemark placed the first dental implant on his friend Gosta Larsen, and those implants lasted until his death. I mean, his friend's death. So it lasted for many years. So in from 1980s to 1990s, there were many implant companies came into the market. Nobel Biocare, Straumann, Zimmer. These companies came into the market, and there were a lot of advancements in the field of implant industry. And in 2000s until today, we have the 3D imaging. It's a digital era. So guided surgery has become very popular, and digital planning, virtual planning of the implants, the CBCT, CAD/CAM technology, everything came into dentistry. And the current trends in implant dentistry is patient-specific implant. In highly atrophic cases where conventional implants are not possible, we can customize our implants. We can manufacture the implant based on the available bone. These type of implants are very commonly used nowadays, where the patient had a trauma, he lost the bone, teeth, or a tumor recession has done, and there is loss of hard and soft tissue. We can try these type of implants. These type of implants are called patient-specific implants. So we will be covering all these topics during our on-site session. Why implants? Why should one incorporate implant dentistry to their practice? Dental implants are the future of restorative dentistry. Long-term functional and aesthetic solution. It's a long-term functional and aesthetic solution. Rising global demand. People are asking for dental implants. If we are not aware of the implant treatment protocols, and if we are not skilled enough to place the implants on patients, how can we treat our patient when they come and ask for implants? And implant treatment, the dentists who have trained in implant dentistry, whose clinical confidence and practice revenue. We all know implant dentistry brings in money. And nowadays we have minimally invasive and predictable outcome. I just wanted to share with you one clinical case. Why should one incorporate implant dentistry into the practice? Here is a case, here is a radiograph where you see the patient has missing upper laterals and an impacted canal. What all are the treatment options we can give to this patient? We have the RPD, we have the FPD, and the dental implant. So when we compare the three treatment modalities, these are the three treatment modalities which we have to restore a missing teeth or missing tooth or teeth. So RPD, very commonly practiced, and there is no surgery involved. Any one of us can make an RPD, just we need to make an impression, send it to the lab. The lab will fabricate the RPD. We just need to place it in the patient mouth. Very cost effective. This has been the treatment of choice for many decades. So when we come to the fixed option, we have the crown and bridges. Here you see a beautifully made bridge. It's a metal-free ceramic bridge. But what about the prepared abutment tooth? For the sake of restoring one tooth, we have to prepare 2 abutments minimum. In this case, they have prepared 3 abutments. So can we call it as a conservative treatment? We cannot. Because for the sake of restoring one tooth, we are preparing 2 or 3. And later what happens? FPDs fail with the loss of abutment tooth. Then what we will do? We will take the next tooth as abutment. We will prepare the next tooth and we make another bridge. This is what happens in our practice. And when it comes to implant dentistry, when it comes to implants, we are not touching the adjacent tooth. We are placing the implant into the bone. Even if it fails, nothing will happen to the adjacent tooth. But the literature says implant therapy has high success rates. More than 97% of success rate is there for implant treatment. There are many studies to support this. It is highly predictable, and we are not touching the adjacent tooth. We are preserving the bone. Nowadays, we are doing immediate loading. So the patient comes to the practice, we place the implant. The afternoon, the patient leaves the dental clinic with the teeth. So patient acceptance is also high with this treatment. So coming back to the case, we have removed the impacted tooth, which was here. We have removed, and we have placed some bone graft material in the defect because we were planning to place an implant. Why we use bone graft? Because we want solid bone in the defect. Otherwise, what happens? If we don't use a bone graft, the defect will be partially filled by bone and partially with fibrous tissue. We all know the epithelium grows faster than the bone. So we did a procedure called GBR, guided bone regeneration. So in guided bone regeneration, we place the bone graft and we cover it with a membrane. We prevent the soft tissue ingrowth to the defect. So that's what we did here. Then we have placed 3 implants. 3 narrow platform implants were placed, and we have delivered cement retained crowns. Look at his beautiful smile. We didn't touch the adjacent tooth. And by placing the implants, we are preserving the hard and soft tissue. Usually what happens is, if we extract and we place RPD, there is going to be bone loss. I'll come to that. And look at his smile. This is the best we can offer to our patients. Look at the smile. We haven't touched the adjacent tooth. And this case was done some 15 years back. And this is the immediate post-op. And these are recent photographs when the patient visited again my practice recently. I took these photographs. So we have predictable results with implant treatment. Only thing, we need to be trained properly and we have to place and restore the implant in the proper way. Another case. Patient reported to practice with missing molars 3, 6 and 4, 7. Again, what all are the treatment options we have? We have implants, we have FPD, but we cannot make an FPD on this side because there is no distal abutment tooth present. This side, of course, we can make an FPD. Can we make an RPD in this case? May not be possible because the patient has lingual torre. It is difficult to make an RPD in such cases. So implant therapy is the only treatment option in such cases. To restore 4-7, there is no distal tooth. We cannot make an RPD. So implants are the only treatment option for this case. And do you think it is difficult to place implant in such cases? The patient has such a good wide bone. Even we can close our eyes and drill. The drill will be inside the bone. That wide is the bone. We get cases with atrophic bone. Of course, such cases are a bit difficult. We may have to do some bone grafting and place the implants. But if you get something like this, like a lingual torre, good wide bone, any beginner can easily place an implant. So that's the importance of implant dentistry, and one should master this technique and incorporate in our practice. So this is how we finished the case. 2 implants were placed and screw retained prosthesis was delivered. There are 2 types of prosthesis, 2 types of crowns. One is cement retained. In the previous case, which I have showed, the anterior case, it was cement retained crowns. And here, what you see is screw retained crowns. We will be teaching you all these in our on-site lectures, and you will also do the hands-on of all these procedures. So what happens after tooth loss? What happens after tooth loss? We extract the tooth. The alveolar bone is present at that time. We make a denture. That is what we commonly do. In completely dentulous patients, after total extraction, we make a denture. But what happens over a period of time? The alveolar bone start resorbing. There is 25% decrease in faciopalatal width within the first year of tooth loss, and rapidly involves a 30 to 40% decrease within the following 3 years. That means 40% of the bone is lost within 3 years after extraction. Why is it happening? It is happening because there is no function for the bone. We extract the tooth and there is no internal stimuli for the bone. When there is no stimuli for the bone to maintain its architecture, the bone starts resorbing. In such cases, if we place an implant immediately after extraction, the alveolar bone levels can be maintained. The bone will stay. The alveolar bone will stay. There will be only minimal resorption, because when we place the implant, there is internal resorption. Sorry, when we place the implant, there is an internal stimuli. So the internal stimuli maintains the architecture of the bone. So in such cases, when we make it complete denture, after bone loss, the vertical dimension reduces. How will we manage the lost vertical dimension? Over a period of time, the bone is going to get resolved. The vertical dimension of the denture is going to get reduced. How will we manage it? We manage it by relining or rebasing the denture. So we are adding acrylic to the denture base. So the acrylic is compensated for the lost bone. In mandible, after tooth loss, there is horizontal loss of bone followed by vertical loss. In maxilla, there is bone loss from the crustal region and also the sinus floor comes down. So at this stage, if we put an implant, it will stay. The bone will stay. But if we leave it like that, over a period of time, the sinus floor will come down and the alveolar bone is going to get resolved. And finally, there will not be any bone to place the implant. So implant therapy not only restores function, it also maintains the bony contour. It prevents the resorption of the bone. Look at this beautiful face. She has teeth, all the teeth present. There is no bone loss. But after tooth extraction, there are changes on the face. Her convex profile became concave. There is wrinkles on the face. Then later, what happens? There is going to be bone resorption. The situation further worsens. There will be a pseudo class 3 relation. The mandible comes forward. A witch chin appearance will occur because of the ptosis of the muscles. So a lot of facial changes happens after tooth loss. We can prevent all these by placing implants. And implant treatment is the only treatment with which we can maintain the alveolar bone levels. Another point, another very important point, the average bite force of the patient. With natural dentition, a person can bite at the force of 150 to 250 psi, pounds per square inch. When it comes to a complete denture, it is only 10 to 50 pounds per square inch. The masticatory, the bite force of the patient is drastically reduced. How can a denture wearer can eat an apple? Can he eat tips? It's not possible. But if we add 2 more implants, 2 or 4 implants in the mandible, and we stabilize the denture, we call it implant overdenture. The masticatory efficiency, the bite force of the patient is increased to 80 to 120 pounds per square inch. If you are making an implant bridge, then the bite force is almost equal to natural dentition. That is 100 to 200 pounds per square inch. So that is the significance of implant treatment. Implants restore function almost equal to the natural tooth. No other treatment modality can give this much advantages. What is a dental implant? A dental implant is a surgical component that interfaces with the bone of the jaw or skull to support a dental processes such as crown bridge dentures or a facial processes or to act as an orthodontic anchorage. What is a facial processes? We all know that if somebody lose one earlobe or nose due to cancer, due to malignancy or due to trauma, we use facial processes. We can fix these facial processes using a dental implant. There are short mini implants available. So that can be, if, for example, one person has lost the earlobe, we can put 2 short implants, 2 or 3 short implants, and this earlobe can be fitted onto the implant. It is very comfortable for the patient. Before we were using, we were attaching these facial processes to spectacles and all. But nowadays we have the short mini implants which can be used to fix the facial processes. During this program, we'll be teaching you all about implants, the implant types, implant designs, implant thread patterns, implant surface characteristics, osseointegration, fibro-osseointegration, so bone implant contact. All these things will be covered during our on-site session. This is a photograph from GCOI conference which happened in Sri Lanka last year. Also, we had the same GCOI conference in Addis Ababa, Ethiopia. So these are our colleagues who had received their credentials, fellowship, mastership, and diplomate during the conference. You need to submit your implant cases or sit for an exam to achieve to get these credentials. During this program, we will also speak about tips and tricks in implant industry, even about the blade selection. It is very important what type of BP, which number of BP blade we are going to use, how to make an incision. We start from the beginning. How to give anesthesia for implant treatment, what type of anesthetic to be used. All these things will be covered. Which number blade to be used, how should you hold the blade, how the incision is made, whether we should hit the bone, whether it is a full thickness flap or a partial thickness flap, when to use a partial thickness flap, when to use a full thickness flap. Can we go with flapless approach? When can we go for flapless approach? All these things will be covered during our on-site session. And we will also teach you about the anatomy of the orofacial region, because we are going to place the implants into the bone. So we must have a thorough understanding of the anatomy of the orofacial region. So we'll be teaching you all these things during the program. We'll be teaching you about the incisive fossa, the canine fossa, what all care should be taken during an implant placement when we are close to the incisive fossa, when we are going distally, and when we are close to the canine fossa, what all care should be taken. We'll be teaching you. In this short lecture, this is an introductory lecture. I may not be able to teach you in detail about all these things. So this is the canine fossa region. And also, we will teach you how to place an implant in the 3-dimensional manner. We cannot place the implant wherever we want. Implant industry is a prosthetically driven entity with a surgical component. So we have to place our implant in ideal prosthetic position. If we place an implant in a wrong position, we may not be able to restore it. So we have to plan our case first. We have to plan the processes first. So according to the processes, we have to place the implant. That is very important. We'll be teaching you all these things in the program. I have seen many failures of implant, many failures in implant industry where beginners start placing implants without proper training. They think that it is, I can pull out a teeth, so it is just putting an implant into the socket. It's not like that. We need to have a thorough understanding of the subject. Otherwise, we will land up in problems. Implants will never fail if we do it properly. Also, we'll be teaching you how to read a radiograph, how to plan your case with the help of CBCT, cone beam CT. I know in Addis Ababa, there are many CBCT centers started recently. So we need to have a CBCT taken before every implant case. So CB and a virtual planning. We can help you in planning your cases. And all of us has to buy this equipment, the implant motor. The implant motor is otherwise called physiodispenser. It is a motor with high torque and a built-in pump. It's basically a micro motor with high torque. Sorry, yeah, it's clear now. It's basically a micro motor with a built-in pump. So when we do the osteotomy or when we do the drilling, the coolant is sprayed onto the osteotomy site. So this machine, we'll be explaining how to use this machine and all the settings about this machine. Everything will be taught during the program. And implant surgical kits. We need to buy an implant surgical kit to start our implant practice. So we will guide you to procure the kit, and also we will explain in detail about the drilling protocol, which is very important in implant industry. How to go about the drilling in soft bone cases, in dense bone cases, in deficient bone cases. All these things will be taught during our program. And we need to have the basic surgical instruments. These things, we have it in our practice. BP handle, blade, periosteal elevator, tissue forceps, needle holder, scissors, bone curettes. All these things, we have it in our practice. So we don't have to buy it separately. Then about sterilization. In implant industry, we are putting something into the bone. In exodontia, we are removing an infected tooth. So when we remove the tooth, we are removing the 4K of infection. It healed by itself. But in implant industry, if we place an infected implant or contaminated implant into the bone, it will not get osseointegrated. It will get infected and it will come out. So 100% sterility has to be followed in implant industry. There is no compromise on sterility. We have to prepare the patient properly, and we have to use pouched instruments. 100% sterilization protocol has to be maintained. And we will teach you during this program how to do all these things. And the drilling protocol, there are different types of drills available with different implant systems. Some drills are coming with stoppers, some are without stoppers, and there are markings on the drill which corresponds to the osteotomy depth, the depth of the osteotomy. And we can also use drill stoppers There are different types of drills. This is DLC drills, diamond-like carbon drills, which are available with some implant systems. And we will also teach you some tips and tricks in implant industry. We are using a dental floss to tie the prosthetic driver. We will teach you why it is done, how it is done, even how to make a knot very fast. All these things will be covered during our program. And there are some special types of drills. These are called bone taps or countersink. These drills are used in cortical bone, in crustal bone. So the usage of these drills, when to use, how to use, all those things will be covered during the program. And there are two types of osteotomy. What is an osteotomy? That is preparing the site. We are drilling the bone or compacting the bone and create space for the implant. So that is called osteotomy. We cutting the bone. So there are different types of osteotomy which can be made. Like there is something called osteodensification. In soft bone cases, we can use osteotomes or denser drills or a magnetic mallet to create an osteotomy. When we use these type of drill equipments, we are not removing the bone from the osteotomy site. When we are using the regular drills, it is like we are using a hand drill and making a hole in the wall, or we are drilling to the wood. We can see the particles coming out. That means we are removing the bone from the osteotomy site when we use the regular drills. When we use an osteotome or a denser drill, we are not removing the bone. We are compacting the bone. We compress the bone. We densify the bone. We improve the quality of the bone. If it is a soft bone, the bone types we will be teaching you. It is D1, D2, D3, D4. So D4 bone is very soft. D1 bone is very hard. So in cases where we have D4 bone, we can use an osteotome or a denser drill, and we can compact the bone. We can push the bone into the marrow spaces, and we can improve the quality of the bone and place an implant. So these techniques will be covered during our course. And selection of implant system, that also we will help you. You know, there are hundreds of implant systems available in the market. Which system is the best for you? We will teach you. We will guide you. By the end of this program, you will understand which system to be bought. And above all, the person behind the wheel is more important. You can drive any car. You can drive a BMW. You can drive a Maruti Suzuki. You can drive a Mercedes Benz or a Range Rover. You can drive any car. But if you are a very bad driver, you may crash. You have to improve your skill levels. That is the most important thing. And we'll be teaching you about the guided surgery. Nowadays, guided surgery is very, very common. We have the CBCT. We take the CBCT image and we manufacture these type of guides. And we will teach you each step in manufacturing the guide. And also, we will train you in guided surgery. These are few surgical guides. This is a partially guided surgery. This is the stand for a partially guided surgery. And this is the surgical guide or stand for a fully guided surgery. And this is how we plan the case. We place the implant virtually with the help of a software, and we manufacture the guide. This is how we plan. And with the surgical guide, we place the implant, and we have to use special type of drills for guided surgery. And this is a case of a single implant restoration. He is Dr. Brian from Zimbabwe, who came for our course in Cochin. So he wanted to have an implant placed to restore his lower six. So we did a guided approach, and he is so happy. He's showing his implant in the laptop screen. So we did a guided surgery, very fast, minimally invasive, and now we are moving towards the era of guided surgery. But guided surgery has many advantages and disadvantages. We'll be teaching, we'll be explaining each and everything in this program. I just want to mention few things which we are going to cover in the program. There are two approaches in implant industry. One is with bone grafts, and there is a graftless approach. Bone grafts, in cases of deficient bone, we must know how to do a bone graft. At least a GBR, a guided bone regeneration, we have to master. So we'll be teaching you the basics of bone grafting. We may not be going into the details of it in depth. We are not teaching you in the basic implant program. We have a different program for that. But the program which is going to happen in Addis Ababa, in our center, dental experts with the support of EDPA, we will be teaching the basics of bone grafting principles. So in implant industry, we get cases with horizontal bone loss, vertical loss, and horizontal and vertical loss. So we will teach you how to manage such kind of cases. These are the procedures which we very commonly do in implant industry. Guided bone regeneration, sinus lifts, block bone grafts, and ridge split. And about the bone grafts also we'll be covering what all types of bone grafts, what graft, when, where to use. All those things will be covered during our program. I just want to share with you one case where we did a GBR, guided bone regeneration. Here, there was an implant placed in wrong position. I have told you, implant industry is a prosthetically driven entity. Implant industry is a prosthetically driven entity with a surgical component. Here, one of our colleagues who has placed the implant labiopalatally, and he had perforated the palatal bone. He was not trained properly. That is why all these accidents happens. So we had to manage this case. The implant was removed from here. This was placed labiopalatally, and you can see the defect. There is a perforation on the palatal aspect. It was a through and through defect. The labial bone is missing, and the palatal bone is also missing. So we have done something called GBR, guided bone regeneration. We started with the osteotomy, that is drilling the bone, and we have placed the implant in ideal prosthetic position. We will teach you which is ideal prosthetic position and how to go about the placement of implant in the anterior region and also in posterior region. Here we have placed the implant in ideal prosthetic position. And this is the titanium mesh which we have used for GBR, guided bone regeneration. This was very old case. This was done some 10 years back. But nowadays we have better titanium mesh than this. Those days we were using these type of meshes. So we have used a mesh and the bone graft was packed inside. You can see the bone graft inside the mesh. And we have stabilized the mesh with the screws. Something which moves will not take up. So it has to be stabilized. There shouldn't be any movement during healing period. So if it moves, the bone will not take up. The synthetic bone or the autogenous bone, which has used as a graft material, should not move during the healing period. So we have to use something to stabilize the mesh or membrane. In this case, we have used a titanium mesh because titanium mesh gives a rigid scaffold. It maintains the space. We need to maintain the space to get good bone. So we have covered the mesh with a membrane and flap mobilization. We need to have tension-free sutures. For that, we have to mobilize the flap. So here we did something called periosteal scoring. We mobilized the flap and this is the closure. Even the suturing technique and the type of suture which we are using are important. We need to achieve good primary closure. Here we achieve good primary closure so that we can expect good bone growth. This procedure is called GBR or guided bone regeneration. This is very commonly done in implant industry, especially in anterior aesthetic zone. Another procedure which we very commonly do in implant industry is block bone graft in deficient bone cases. Sometimes we have to do block bone graft. You can see this photograph. Central incisor is missing, but clinically it appears to be good bone over there. But you see this, clinically there is bone. But when we took the radiograph, the bone was very deficient. Only the labial plate was present. So we harvested the bone from the ramus area. A block was taken and the harvested block was placed at the receptor site. This is the receptor site. Only the palatal plate was present. There was no labial bone. We cannot place an implant. If we place an implant, without the labial bone, on a later date, the implant threads are going to get exposed and there will be aesthetic issues, especially in the aesthetic zone. So you need to do a guided bone regeneration or a block bone graft. Here we did a block bone graft because there was literally no bone, only the palatal thin cortex was present. So the harvested block was fixated there and you can you can see the screw which I have used to stabilize the block. And we used the particulate graft and covered it with a membrane and closure. This is another procedure which we do in implant industry to build the bone, to grow the bone. You can see the block bone fixated with the screw. This is the CBCT cross-section image. Then we will also teaching you about the sinus lift procedures. Many of the cases, more than 50% of the cases in posterior maxilla, we get needs sinus lifts. And there are two approaches to the sinus. One is crustal and the other one is lateral approach. As a beginner, it's very easy to do a crustal approach. We will teach you the tips and tricks to do a crustal approach in a minimally invasive way. And also you can place the implant simultaneously. That is called MITSA or minimally invasive transcrustal sinus augmentation. So here in the CBCT axial section, you see there is a compartment, there is a septa present in the sinus, and the sinus has two compartments. And in CBCT section, you see the bone height is very less. So we had to do a sinus lift procedure. So this is how we do the procedure. The osteotomy is done and we use the tensor drills and we pack the bone in the sinus. You see the umbrella shape. That means the procedure is successful. There is no membrane rupture. And the mesial bone graft is done. And we go to the distal compartment. And there also we did another lift. So two sinus crustal lifts were done in one patient. And we have placed, you can see the bone graft in this case, and we have placed two implants in a very minimally invasive way. You can see the incision. There is not even a releasing incision. Only the mid-crustal incision is done to do this procedure. And we have to wait for some time and we can restore the case. I told you about the graftless approach. The previous cases, we did bone grafting. But we can also handle the cases without bone grafting in posterior maxilla. The maxilla is divided into three zones, zone 1, zone 2, zone 3. If we have bone in all the three zones, we can place straight implants. If we have deficient bone, then we have to go for tilted implants. That is all on 4, all on 6 technique. If there is no bone in all the three zones of maxilla, then we have to go for extra maxillary implants. All those things will be taught during the program. And I just want to tell you about the all on 4 or all on 6 treatment. Here is a case where we have done all on 6 treatment. The patient has missing teeth in the maxillary jaw and he had only few teeth present and that too was not in very good condition. So this is the X-ray of the patient. There was no bone to place implants in the posterior maxillary region. So we decided to tilt the implant. That is the all on 4 or all on 6 approach. We decided to tilt the implant and restore the case immediately. So we did a virtual plan. This is the CBCT of the case. And we planned the implant with the help of a software. First, we plan the processes. Then we place the implant in proper positions. And this case, we use a pilot guide. Digital Dental Solutions is our center where we help our colleagues to plan the case, digitally, virtually plan the case, and also to manufacture surgical guides for their cases. So a surgical guide was made. This is just a pilot guide, not a fully guided surgery. It gives the accurate direction of placement of the implants only with the pilot drill. Only the pilot osteotomy can be done through this. It's not a fully guided. This is after flap reflection. The osteotomies were done and these are called paralleling pins which were placed into the osteotomy and the implants were placed and multi-unit abutments were attached, we were planning to do the case immediate load. Immediate load was planned for this case. And this is how we finished the placement. You can see the sinus floor, an anterior wall of the sinus and sinus floor. The implant is placed in such a very accurate position using the surgical guide. Both sides, the tilted implants were just anterior to the sinus floor. And we have placed 4 axial implants, that is the straight implants also placed. And this case, we made a conversion processes. We converted the patient's denture into a fixed processes. We'll be teaching you these techniques in our hands-on session during the on-site module. This was the denture which we made for the patient, upper denture, and we converted the denture. This is just a provisional restoration, a temporary restoration. Until the implants are integrated, we can use this. Want to change the battery? So I was talking about the conversion processes. The patient's on denture is being converted into a fixed processes. This is called conversion processes. The patient come to our practice in the morning. We place the implant, and in the afternoon, we deliver this processes, and patient leaves the dental office with the fixed processes. So morning the patient comes, afternoon the patient leaves. The patient acceptance is very high for such surgery. This is the processes, not that great, but something for the time being we are delivering to the patient. It's called conversion processes. This is how we delivered the process. Same day afternoon, the patient left the office with the processes, fixed processes. Yet a removable processes was converted into a fixed processes. And this is the post-op radiograph of the case. And later, this is a smile. And later we remove the conversion processes or the temporary processes and look at the soft tissue healing, very beautifully healed soft tissue. Now it is ready for the final processes. We make impressions and we made the PFM, porcelain fused metal, that is the ceramic processes was delivered. So this is how we finish the case. A word about extramaxillary implants. These things are also covered during our program. So you see this case, bilateral posteriorly dangerous area. Both sides, the patient has missing teeth. And this case is very important to me because this patient is a dentist and he was my classmate during my dental studies. So he came to me, he had missing posterior. Being a dentist, he lost all the teeth. He was not taken care properly. Maybe he was busy treating other patients. Anyways, I had to fix implants for him. There are 2 options. One, we have to do bone grafting, wait for 6 months and place the implants. The other option is we can go for tilted implants, bypassing the maxillary sinus. We place 1 implant tilting anteriorly, 1 pterygoid implant that is tilted posteriorly, and we can load it immediately. So we plan for the graftless approach for him. So this is the intraoral photograph, and we started with the pterygoid implant. And you can see the driver and the drill. And this is how we place the pterygoid implant. We need to have the long driver to place the pterygoid implant. And the other side also we did a flapless approach. It was a flapless case. We didn't reflect the flap for placement of pterygoid implants. And always we take a CBCT to check whether the implants are placed properly, because pterygoids are a blind procedure. Pterygoid implants is, we cannot see the tip of the implant, the apex of the implant. So always we check it with a CBCT. And this is how we did the placement. This was the maxillary sinus, an anterior tilt, a posterior tilt, that is the pterygoid implant, and one straight axial implant. The same thing on both sides. And made the impression on the same day after surgery, and restored the case on the third day. We made impressions and sent it to the lab, and the lab fabricated the processes within 2 days. And we finished the case like this. So I hope I have given a broad idea about what all things are covered during our program. And in Ethiopia, we are starting the program, that is the on-site module, on 28th of this month. We have 16 participants registered till date. We have 4 more seats available. Any one of you wish to join for the program, you are welcome. And the first 4 days, every day morning we will have lectures, and every day afternoon we will be doing either patient hands-on or model surgeries. Participants has to bring their own patients, because I think you all are practicing in Ethiopia. So you can bring your patients. We will guide you to place the implants on the patients. We have a full-fledged operatory with all the facilities there at Dental Expert Center in Addis Ababa. And the surgery, that is called the surgical module. It will be of 4 days. And there will be online sessions in between. After the surgical module, we have to wait for 3 months for our implants to integrate. We will be placing implant on patients, and we wait for 3 months, and we will have another session. That is the prosthetic module. The prosthetic module is going to be in October last week. That is after 3 months. So that time also our team will come to Addis Ababa, and we do the uncovery, implant uncovery, impression making, and delivery of the processes. All those things will be done during the prosthetic phase. And during the prosthetic phase also, every day morning, there will be lectures, and every day afternoon, you will be doing hands-on or patient surgeries. So this is how we structured the program. This is a 100 hours program, including the online and on-site sessions. And for more information about this program, you can contact EDPA or Dr. Satyun, who owns the center, that is the Dental Expert Center. You can contact her or Dr. Meron or Fasik for registering for the program. Hope I have given an overview about the program and implant dentistry in my lecture. And thank you for your patient listening. Have a good evening. And any questions regarding my lecture and the course, you can message me or to EDPA. This is my WhatsApp contact. You have to add +91, that is the India code, +91 944 77 96026. That is my WhatsApp contact. You can ask the questions on WhatsApp, or you can mail your questions Dr. Jabin at gmail.com. You can follow on my Insta. I'll be posting regularly my cases on my Instagram. This is my Insta ID. Hope you enjoyed the lecture.